Good morning, everyone. It's a great pleasure to be invited here. I'm certainly very humbled to be amongst esteemed speakers and all the clinicians and practitioners here. I'm used to being in the audience, so this is one of my first times being actually on the stand, so I hope you'll bear with me. So my background is actually a pharmacist, and I've also had the chance to do a PhD in clinical pharmacology. I looked at anti-cancer drug discovery. So I've worked a bit in academia, and I've had a bit of a pharma experience in a biotech. I've then gone into functional medicine, and it's completely changed my life and my practice, not just from patient's point of view, but even personal and friends and family. So it just opens up new avenues. So today I'm going to be talking about management of long COVID, and so I've had a personal sort of experience with that as well, in a sense that I've suffered long COVID in 2020, and it's been an interesting and definitely a painful journey. So I do feel the patient's journey, and there was a lot of self-discovery. So I've so some mentors like Sarah Mayhill's books definitely helped, and and lots of the speakers here today. So I'll get straight into it. So the first slides Rachel has already covered. I've shown that just to show that it can be known as different names, and when looking at the literature, sometimes it's useful to just have a unified name. So unfortunately, you might have to search for different names. And as defined, sort of signs and symptoms usually is what carries on after 12 weeks, which is not explained after, by another diagnosis. Prevalence is mentioned as well by Rachel. So in the REACT-2 studies, it's about 37% as reported in 2020. It's certainly, I think the main thing to highlight from that is that it affects a large chunk of the population. Signs and symptoms, Rachel has already gone through that, so I'm just going to quickly scroll through. So these are the ones I've highlighted, are the ones I see the most in my practice. And, as you can see, affects lots of organs. So there's they can be varied. So sometimes it might be hard to miss it, in a sense that, you start thinking what's going on, what could have been the cause. So long COVID seems to present as many sort of symptoms and signs. So you've already seen this slide. Main message from here is that ACE2 receptors are the entry point or the gates for the virus, for the SARS-CoV-2 virus. And this was reported from the BMJ paper in 2021. I'd like to speak a bit about MCAS and it's already been mentioned briefly before, but I just thought it's quite interesting because it's one of those things that I see a lot with certainly with my patients. So it's certainly something that, so just talking a bit, going into basics. Mast cells are a type of white blood cell. They're considered the first line of defense, usually where outside meets the inside, meaning skin, gut lining, etc. And what happens in the normal mast cell activation is you get a release of histamine and other cytokines, and it's when this doesn't correspond to an allergen or an anaphylaxis as such that it becomes a bit disproportionate. So patients start experiencing these symptoms throughout multiple times, and in this instance it's actually being caused by a virus. So that's I read this quote from one of the American speakers, and so they've described it as if there was dispatch calling the whole SWAT team over a spill of coffee at Starbucks. So, which is exactly a bit of what's happening here. So, and what's the link between MCAS and long COVID? So there's definitely a link. There's lots of publication that have looked into that. So the Weinstock paper in 2021, I'm just going to quickly read this quote. So, MCAS symptoms were increased in long COVID and mimic the symptoms and severity reported of patients who had MCAS. Increased activation of aberrant mast cells induced by SARS-CoV-2 infection by various mechanisms may underline a part of the pathophysiology. So it's important for us to think about therapeutic approaches by looking, whether the patient presents with MCAS. And I thought it'll be useful to show this spider web, diagram from the same paper, Weinstock paper in 21. And the main thing you can see from here is that, MCAS patients prior to therapy show an almost pretty much an identical presentation to post-COVID, long COVID patients. So lots of symptoms, lots of organs are affected in the same way. The ones on the left are control. So let's jump into management. And generally, there's no established protocol for managing long COVID patients, and that applies for NHS as well as private. So it's not, so it all depends obviously on the signs and symptoms. So if the patient is breathless, for instance, and we look at cardiological issues. So we do a cardiac echo to exclude myocarditis, a CT pulmonary angiogram to exclude chronic recurrent small PEs, and a CT chest to look at COVID damage to the lungs. And that's usually, so when I get patients, usually they've already gone through this process, and I look at what hasn't happened from a functional point of view. So there's lots of investigations that need to be done, and I think it's important to work with the GP or other clinicians or other consultants. Interesting things to note, I was speaking to someone before, is that sometimes it's not always easy to get through to the NHS, especially you're describing, they might see your symptoms as being mild. They might not think that it's a long COVID. So it is an unfortunate scenario for patients, and a lot needs to be done to recognize. I mean, long COVID is being recognized, but just to get patients to get through the system and have all these tests. So we do get lots of patients going privately, but not everyone could unfortunately afford private treatments. So so there needs to be ways to speed up the processes and help our patients. So what I'll be discussing today is many evidence-based supplements that can help long COVID symptoms, and I'll be providing a bit more details. So I've put this list together of supplements that I've got personal experience. I like to use in my practice, and I'm sure the audience knows a lot more probably about those than I do. And I've highlighted the ones that I will be going into a bit more detail. So baseline immune boosting, stabilizing the MCAS. I think there's something that we're not seeing there. And then you've got some stuff to help with the neuroinflammation. So I'll jump straight to the therapeutic approaches. So what I'll do in the next slides is I'll be going through these approaches and showing the evidence behind it, as well as speaking a bit from sort of my own experience and how I would use it. So I would start with luteolin, as you probably know, is a bioflavonoid, and it's a great addition it's been a great addition to my practice. So I'll just look at this paper from Theoridis group, where they've done the long COVID syndrome associated brain fog, and how luteolin helped those patients. So as it's already been introduced, COVID might trigger inflammatory response. Usually that is through a cytokine storm and interleukins. We've established that symptoms could be similar and probably in some cases identical to CFS, ME, and MCAS patients. So there's an elevation of IL-6. So what happens is the virus can stimulate the hypothalamus to produce mast cells and microglia. And microglia, accumulate all that toxins, stays in the system, and accumulates in the brain, but body finds it hard to get rid of it, and then you have neuroinflammation. So things like luteolin and quercetin, and I think we're talking about liposomal formulations, better absorption, because they have they're quite structurally similar, and they could inhibit mast cells and microglia neuroinflammation, and ultimately they've been shown in this study to reduce brain fog. So this little diagram shows a bit of a simplified pathway on that. So you've got SARS-CoV-2 that makes the entry through the nose, and then you stimulate the hypothalamus. You've got the activated mast cells, with the messengers being the interleukins, and then you've got the accumulation of microglia, and then you have the key, the brain fog reported by pretty much most of my patients. So you can see that luteolin has been shown to inhibit a lot of these pathways, ultimately reducing and eliminating that. The next supplement I'm sure you're all familiar with is glutathione. I'm a big fan of glutathione. I use it with pretty much all my patients, myself. We go through the reduced form of glutathione as being the master antioxidant. And one thing that was highlighted specifically with glutathione in this paper is the ACE and ACE2 balance, angiotensin converting enzyme. So the more ACE we have, the more vasoconstriction, the more inflammation, the more oxidative stress. So what tends to happen with the SARS-CoV-2 virus is it downregulates ACE2. So there's more of ACE, and then you've got all these things happening. And that's where the magic comes. That's where glutathione GSH comes as being a master antioxidant. So it would reduce oxidative stress by reducing rapid oxygen species and reducing the pro-inflammatory cytokines, downregulating the inflammation. And this diagram from the same paper from the Italian group, Silvagno et al. 2020, shows how GSH inhibits rapid oxygen species, inhibits the accumulation of ACE, therefore shifting the balance towards ACE2. So as a result, this exacerbated inflammation would reduce, and you have less of a cytokine storm. Next one is NAD+, as you probably all know, is a hydrogen transporter, is important for mitochondrial function and producing sort of energy in the cell. So you've got so one thing that was pointed in this paper by Dave Sinclair, just been published in the last couple of months in Cell Press, a very interesting paper. I really encourage you to have a read through it. So NAD+ has been shown to have antiviral, anti-inflammatory properties. We think of it as mitochondrial boost, but there's a lot more that it can do. Interestingly, old age, diabetes, cardiovascular diseases have low levels of NAD+. And who are the patients that are most affected, by COVID and long COVID? It tends to be in this group of population. Viral infection tend to reduce further the levels of NAD. So, you've got two things happening there. And the main thing that's happening is that, the SARS-CoV-2 virus, possess an ADP ribosyl hydrolase that counteracts the effects of the NAD, therefore stimulating, more NF-kappa B, which are the bad cytokines. So NAD+ stimulating compounds. So you want to bring up the levels of NAD+ through precursors, NMN, nicotinamide riboside. I don't know if you're familiar with those. Alternatively, you can do it intravenously, and this might block the action of the inflammasomes and reduce inflammation. So melatonin is a great addition to the to the toolbox of supplements and therapeutics approaches. And we tend to think about it, at least I did in the past, as a sleeping aid, but it's a lot more than that. So it's been shown in this paper that it has it's a potent inhibitor of neutrophil MPO myeloperoxidase, which is thought to contribute to oxidative stress. It scavenges your rapid oxygen species related in response to a viral infection to eliminate viruses. And it also, as a result, it's got both antioxidants, anti-inflammatory, and immunoregulatory properties. So with my patients, I always try to give them melatonin. Certainly would help them with the sleep, but it's giving them that, sort of baseline of antioxidants and, anti-inflammatory effects. So low-dose naltrexone is something that I have started prescribing in the last few years, and mostly with my autoimmune patients, as well as helping patients with analgesia, where other things, they're taking a lot of things and it's not working. So let's give them something that's very minimal side effects and minimal risk. You start low and you go slow. And so very interesting paper that reported repurposing of it. So this came up in February this year, of low-dose naltrexone for the prevention and treatment of immunothrombosis in COVID-19 patients. So SARS-CoV-2, as we said already, they've got an increased risk of thrombosis. This is due to an increase in interleukin-6, 1, TNF-alpha, as well as D-dimer and tissue factors. So LDM being a competitive opioid antagonist, will have those anti-inflammatory effects. So it could modulate the thrombotic changes by, through different mechanisms, NET, neutrophil and products formation, platelets, fibrinogen. So this goes into a bit more details about the mode of action. So I won't go into that, but you've got all different modes of actions on how we would reduce the viral load, cytokine production, as well as the first release of the cytokines. So transfer factors, I didn't use transfer factors in the past. I started using them with, when I had long COVID, and from a personal experience, they completely changed. They're great addition, as you probably know. So they have, so there's been more publication coming on transfer factors. The main thing, I like to think about transfer factors is that it's an immune booster. How they boost your natural killer cells through direct interaction between transfer factors, as well as activating the receptors on the surface of natural killer cells. So what are they? They're immune, they're immunostructures. They're messengers, let's say, and they're made of oligo and polypeptide fractions, usually from colostrum. There's other sources, and the source can make an impact on the quality and the use of it. So what they do, so they're released from T helper cells, and as they release, they send a message to other T helper cells to eliminate pathogens, release more T helper cells, natural killer cells, macrophage, cytotoxic cells. So why wouldn't you give this to your patient? They're really amazing with those patients with very low levels of natural killer cells, etc. This tells you, this is from a book by Ann White in 2009, A Guide to Transfer Factors Immune System Health. Just goes into how the virus enters, phagocytes takes that, presents it to Th1CD4, it gets tagged, and then, eliminated further. The last point, the last therapeutic I'd like to talk about is ozone therapy. I use ozone a lot in my practice, and it's definitely, been great help for myself and my patients. So this was an interesting study published by the Italian team in 2021. So they've looked at the fatigue element in post-acute sequelae or long COVID patients, and they've used autoheme therapy. So autoheme therapy, for those of you that are not familiar, is basically taking a bit of blood, say 100 ml, ozonating it, and the blood goes back in. So they've done that in the Italian study on 100 patients, and the main thing I want you to, so it was a two to three times a week for 2 to 3 weeks, and they've assessed after 1 week. So all patients had an improvement, 67% having significant improvement, and this is amazing. I mean, you get chronic fatigue patients, it's quite something. And the main thing about it is that it's supposed to exert, its effect on the endothelial dysfunction and as well as long COVID. This is another study where they looked at potential therapeutic effects of oxygen ozone in controlling COVID-19 disease, and they've gone a bit more into the mode of action. Obviously, it's certain things are a bit hard to prove, and we need more data. But it's an interesting theory of how it would work. So reducing interleukins, interferons, having anti-inflammatory effects, reducing the cytokine storm. So it's the same things that seem to be happening with various things. And I've seen that with my patients, and it's quite amazing, reducing the dimer fibrinogen. So this goes a bit more into the mode of action. So you've got ozone therapy, inhibits oxidative stress, inhibits inflammasome, inhibits NF-kappa B, and reducing ultimately cytokine storm. This is another paper about ozone, and the main message from this paper being, systemic ozone therapy seems useful in controlling inflammation, stimulating immunity, and as well as having an antiviral effect. It's providing protection from acute coronary syndromes and such as ischemia, ischemic perfusion damage, and those suggesting this could be a new methodology in immune therapy. And Italians use it a lot. They've used it a lot during the COVID pandemic. South American group as well. There's lots of group around the world that use it. It's a bit of a shame that we don't get to use it as much in the UK. So I'm going to talk about case studies. So I've just selected 2 case studies from my patients that I thought would be of interest to the audience. So first, the patient is a 38-year-old female, mother of a young child, works from home as an artist. She had COVID in February 21. So 12 weeks after the initial symptoms, she came to see me with long COVID symptoms, fatigue, tingling, post-exercise malaise, headaches. She had several blood tests. She's going to see she went to see her consultant privately as well as her GP. Nothing significant was observed initially. She was otherwise, fit and healthy. She didn't have any predisposition. In a sense, she was taking thyroid. I did an MSQ for her, for those of you that use MSQ, and it showed severe toxicity. We started IV therapy at AD plus and Myers at the time, and we discussed doing investigations. So this is just to show you what an MSQ is, quite comprehensive in a sense, just gives us a bit of an idea what's happening, and it's good for follow-up as well. Sometimes you might miss something. So usually I see my long COVID patient falling into the moderate toxicity, sort of 50 to 100. And just wanted to show you a bit, without going into too much details, sometimes we miss things, but, here, I thought, okay, there has been a recent activation of EBV and, interestingly, IgE elevation, which I've seen pretty much in almost all my patients. So again, the MCAS question. So with this case, with this patient, rang her a couple of weeks, how you been doing? She's doing well, but okay, I haven't seen her again. So she came back after 6 months in December, and symptoms were getting worse. So, she's been now diagnosed with myocarditis. So she had brain inflammation, MRI with contrast. She's even had to do a lumbar biopsy. Unfortunately, she's had gadolinium. So, she was having low energy, low mood, brain on fire, very anxious. Her MSQ is still elevated. So cardiologist prescribed, bisoprolol, colchicine, pregabalin, prednisolone. So I thought, what, let's do a bit more investigation. Let's look at your gut. Let's look at your biotoxin. Let's look at, doing some co-infections. Let's see what's happening in the background, which is often the case. There's something else that's happening. So let's reduce, as much pressure on the immune system to try and stabilize this. So, and we started doing ozone, MAH twice a week, Myers twice a week, and I referred her for lymphatic drainage with Perrin therapists. Prescribed a number of supplements. Main thing that came up from the GI effects is, high level of inflammation, high level of dysbiosis. I've given her some supplements and a low FODMAP. So interestingly, there were some reactivation. She wasn't a Lyme patient as such, but there was an elevation in Borrelia, and then some mycoplasma. EBV wasn't as significant now, but the main thing, her CD57 was 40, which is extremely depleted. Gillian is an expert on that. So we looked at her mycotoxins. She mentioned mold, and yes, there was a lot happening in there. So after doing the interventions, patient started noticing more energy. She was able to spend Christmas with her family. She had planned to travel in the year, which is something she could even think of, leaving her house. And now she's planning to travel. Unfortunately, she had COVID again in early January. We'd like to think that she was a bit better equipped this time, but she didn't have any hospital admission. The only things that increased were her thrombotic markers. So she had to take antibiotics, had chest pain, breathlessness. MSQ is one of my very health conscious, anxious patients. It was very elevated. And so we carried on doing ozone and Myers, up a bit the doses of vitamin C and glutathione. And, after there was less hair extraction, got to do some more lymphatics. I've given her some supplements, so transfer factors, for those of you that are familiar with this brand. So transfer factors, some glutathione, some antioxidant, as well as RG3, which I like to use for neuroinflammation, and Beautiflam, which is butyrate essentially. So after 8 weeks post-COVID, the patient was almost, and that's after doing the intervention, the patient was almost symptom-free. So she traveled to the Caribbean, had great holidays, and this is a patient that was feeling, literally couldn't get out of bed, was struggling to even come to the clinic, 80% improvement. So had a long trip, to the Caribbean. So back to exercise, more motivated, less stress. I saw her a couple of days ago, really, really happy, and, just looking forward to things. Her MSQ was much better. Second patient, so 39-year-old mother of 3 kids, used to be very energetic, worked in the NHS, she's sporty, did a lot of activities. In March 2020, same as I, she got COVID. She didn't have to be hospital admission, have any hospital admission, and she had some moderate symptoms with fever. So about a year after, she had symptoms of long COVID, which included fatigue, malaise after walking a few steps, weakness on one side, tingling, and arthralgia. MRI didn't show much. Breathlessness and palpitations were still present, so element of POTS there as well. She's had some vitamin infusions with another clinic. It helped slightly, but nothing significant. She was put on a low histamine diet, which was great, gluten and lactose free. And she's been prescribed some supplements as well, from the ones you can see. So her MSQ when she came to me was 57. We started doing some mitochondrial IV infusions, which is your vitamin C, your zinc, magnesium, selenium, B12, B complex, and lots of aminos, NAC included. And we build up the levels of vitamin C, with every session. And then, she wasn't too keen on doing lots of money was an issue. So we just looked at the co-infections. And so I think we're not seeing, maybe it's just that. So the main thing that was, her CD57 absolute was quite low, 55. Her EBV was +3. Her CMV was extremely elevated, +9, +10. And so there was a lot happening in the background. There were some viral infections. So again, I've put her, in addition to the other previous therapies, given her a cocktail of transfer factors, some mitochondrial boosters, some antioxidants, some glutathione, butyrate, and the other things. And I kept reviewing her every couple of months and changing. So after 6 months, she reported 80% improvement, which was amazing. This is a patient that really had suffered and gone through a lot. She still had some symptoms present. Her MSQ was 21. I was thrilled to see that. She was back to exercise, feeling grateful, more content. And, I said, look, we still have to carry on with certain things, at least from a diet and supplements point of view, because, it says symptoms disappear to an extent, but I think there's always something that stays in the background that's important to make a note of. So I do use other approaches as well, I'm sure as you do as well. And so diet is very key. So if you give them the best therapies and, you haven't fixed their diet, you haven't reduced the pro-inflammatory, you're not going to get far. So low histamine diet for those MCAS patients, and I like to use a low FODMAP diet for some, and these things worked for me and my patients. I usually recommend them to go for lymphatic drainage. I like to refer to practitioners that use Perrin technique. I find it very useful. I still do that myself, very helpful. And some of you might know Dr. Perrin, and it's the idea from it is that it helps to reduce the overload of the sympathetic nervous system, to reducing the buildup of toxins and the fluid around the brain. And other things are, conscious movement, exercise, for instance. And there's a lot more, meditation and smell therapy for patients that have had issue with that. So just to summarize, long COVID is a post-infection multi-system chronic illness. It has very similar characteristics, to chronic Lyme, CFS, and MCAS. So approaches to reduce chronic inflammation, support the mitochondria, target MCAS, and a few other things, have given us the tools to already know what to do with the long COVID, which is great. We've learned from those who have recovered, and I definitely don't have a rigid approach. I change my approach based on, with every patient, but I learn something new every day, as I'm sure you do as well. So that we need to have more double-blind placebo studies. And the main message I'd like to say is that there is hope, and which is with all patients that come see me. We can't cure you overnight, but just bear with us, and hopefully there's a way forward. So these are the references I've used, and if you have a chance to read some of those, I have the full version, so I'm happy to send to anyone. This is where I practice. I'm based in the Zen Knightsbridge. We've got 3 clinics in London, and feel free to send me an email for any questions. And thank you.